Hello and welcome to our presentation on trauma and crisis. We're going to take a look at crisis intervention teams. Our team consists of Amanda King, Amy Worley, Ann Collingham, and Jessica Kroeger. What is a crisis state exactly? So that is different than the definition of crisis, which we'll discuss in the next slide. A crisis state involves the breakdown of coping behavior that may have been adequate in the past, and as such, it is a departure from the norm of the caller or client or patient. A healthy, well-adjusted individual can experience a crisis, as can someone who is mentally ill. The goal in crisis intervention is to assist the patient, client, civilian in returning to whatever is normal for them, hopefully armed with new, more effective coping skills. We all experience a variety of stressful events in our lifetime. Each of us has unique ways of dealing with these events in order to maintain a comfortable emotional balance, and when the usual coping mechanisms fail, we seek new ways of coping. A crisis state comes into being when these new attempts fail to return us to the pre-crisis level of emotional balance. Crisis is a state of feeling, an internal experience of confusion and anxiety to the degree that formerly successful coping mechanisms fail us and ineffective decisions and behaviors take their place. As a result, the person in crisis may feel confused, vulnerable, anxious, afraid, angry, guilty, hopeless, and helpless. Perceptions are often altered and memory may be distorted. Crisis is both a time of opportunity and danger. Crisis is useful when it causes one to go beyond familiar coping skills, both internal and external, and to develop new skills, therefore becoming more competent and autonomous. A crisis is dangerous when the person becomes overwhelmed with anxiety and pain and adapts in negative ways. There are different types of crisis. We often think of a crisis as a sudden unexpected disaster, such as a car accident, natural disaster, or another cataclysmic event. However, crisis can range substantially in type and severity. In developmental crisis, these occur as part of the process of growing and developing through various periods of life. Sometimes a crisis is a predictable part of the life cycle, such as the crisis described in Erickson's stages of psychosocial development. In existential crisis, inner conflicts are related to things such as life purpose, direction, and spirituality. A midlife crisis is one example of a crisis that is often rooted in existential anxiety. Situational crisis. These sudden and unexpected crises include accidents and natural disasters. Getting in a car accident, experiencing a flood or earthquake, or being the victim of a crime are just a few types of situational crisis. We're going to take a look at what trauma entails and how the nervous system reacts to trauma. So initially, trauma is physical or emotional threat or harm. It can be intense fear, helplessness, or feeling loss of control. How it impacts the nervous system is through fight, flight, or freeze. Experiencing trauma may or may not be traumatizing. Everyone responds differently. When you're not able to stabilize or self-regulate, it distorts the meaning of the event. Significant and continued instability of physical and mental health, unstable behavior, lack of resilience in person-family relationships, disconnected from community and spirituality. When you're able to stabilize or self-regulate, makes positive meaning of the event. For example, recovery of physical and mental health, stabilization of behavior, resilience in the person, family, and relationships connected to community. I like this infographic on the nervous system. It does a good job illustrating the three different areas of our nervous system, the parasympathetic, the sympathetic, and, well, I should say the parasympathetic of the ventral vagal, the sympathetic nervous system, and then the parasympathetic of the dorsal vagal. So let's begin with the parasympathetic nervous system. This is where we are feeling calm, connected, we're grounded, we feel safe in our environment, we're oriented to the environment, we're in the present, we feel relaxed enough to be curious, and we're open. Let's see, our digestion increases, our intestinal mobility, so there's biological things happening within us, decrease of defensive responses because we're in a relaxed state. Moving on to the sympathetic nervous system, this is that fight or flight moment, or moment. Either in the fight, we're going to experience rage, anger, irritation, or frustration. In the flight, we want to move away from whatever the situation is, and that includes panic, fear, anxiety, worry, concern. At this time, biologically, our blood pressure is increasing, our heart rate is increasing. What's decreasing is our fuel storage, our insulin activity, our digestion, relational ability, and our immune response. And the last is the parasympathetic nervous system of the dorsal vagal complex. So this is our freeze stage. This is where we become numb, we shut down, we feel trapped, hopeless, helpless, depressed. And what's happening biologically is fuel storage and insulin activity increases, immobilization of behavior with fear increases. What decreases is our heart rate, our blood pressure, temperature, muscle tone, facial expressions, and eye contact, which is a lot of times when we'll find someone in a freeze moment, but they have that flat affect because they are frozen. So I like this infographic. It does a good job of describing what's happening within our nervous system during a fight or flight or relaxed state. This is another great infographic on trauma in the brain. You can see here the amygdala, which affects the emotional computer and alarm system, the hippocampus, brain storage for our most recent conscious memories, thalamus translates sights, sounds, smells into the language of the brain, and the prefrontal cortex, where information is used to make decisions about cognitive and emotional responses. So these four parts of our brain are actively engaged during a traumatic process.
As stated previously, anyone can experience a crisis that can cause trauma.
We examined what trauma does to the nervous system and the different parts of the brain that are affected.
So now we thought we should examine trauma-related diagnoses. The DSM-5 identifies 5 trauma and stress-related disorders. Each of these disorders has diagnostic criteria where traumatic or stressful events have been experienced. These disorders are closely related to anxiety disorders, obsessive-compulsive disorders, and dissociative disorders. As it was stated previously, responses to traumatic events can be quite variable. And despite this variability, the DSM states that most prominent clinical characteristics of these disorders are anhedonic symptoms, which means that people will have a reduced ability to experience pleasure, and dysphoric symptoms, feeling very unhappy, uneasy, or dissatisfied. They may also experience externalization of anger and aggressive behaviors, and experience dissociative symptoms, meaning disconnection and lack of continuity between their thoughts, memories, surroundings, actions, and identity. These disorders may also include fear or anxiety-based symptoms, which can make the differentiation between the closely associated disorders a little bit more difficult. For PTSD, the clinical presentation and symptom onset and duration varies quite drastically. But the main gist to this disorder is that someone has experienced a traumatic event and they are having a difficulty adjusting and coping to the experience to the point that it's negatively impacting their day-to-day functioning. Adjustment disorders are emotional and behavioral reactions to stress. These stressors can be single, multiple, continuous, or even developmental events. They occur usually within 3 months of the stressor onset and end no longer than 6 months after the stress ends or the consequence ceases. However, for continuous stressors, that may cause persistent adjustment disorders to be present. Acute stress disorders basically have all the signs and symptoms similar to post-traumatic stress disorder, but the key component is the duration of the disorder of symptoms. So for ASD, it occurs within 30 days after the person's exposure to the traumatic event, thereby it being acute. Disinhibited social engagement disorder is a childhood attachment disorder. Basically, it means that they have a lack of fear towards adults, strangers. They don't have any hesitation around strangers, and they And this lack of fear or hesitation towards strangers is outside the norms of typical childhood behavior. Reactive attachment disorder is a condition in which children are unable to connect with others or manage their emotions.
The next slide is the prevalence rates and risk factors. And this one really is just trying to identify how we got here, how we got into a situation where these teams needed to be added to assist law enforcement. And so it's the need for crisis intervention teams has increased due to the lack of funding for mental health in our government, which has led to less mental health services available for those that are struggling with mental illness. And a lot of the funding, from what I read, actually started to decrease significantly back in the 1960s and then has just progressively occurred over time. And due to this, lack of funding, obviously the services are no longer available, which leads people to not get the help that they need, which leads to tens of millions of people in the United States are struggling now with a form of mental illness each year, and only half have received the treatment, the treatment that they need, leaving a significant opportunity for a crisis to occur within these untreated individuals. So it just shows that, as we continue for these individuals to go untreated, thus it's leading to crisis situations. And obviously now, a need to add assistance to our first responders so that they can, be properly equipped to go into these situations. According to the Journal of the American Academy of Psychology and the Law, police officers fatally shot 1,000 people in 2018, and people with mental illnesses accounted for 25% of these deaths back then. Today, this statistic remains at a potentially higher rate. It's as low as 25%, but even could be as high as 50% of these shootings and deaths are happening within the mentally ill. And again, so it signifies why, we need to get a better handle on how to handle these situations so that obviously we don't have so many deaths occurring as a result.
2 million people with mental illness are booked into jails each year. Nearly 45% of those 2 million have a serious mental health condition. And once in jail, 83% of those 2 million people did not have access to the needed treatment and their conditions worsened. In most cases, the incarceration duration were longer than those without mental health conditions, and those with mental health conditions were more likely to be victimized.
The other statistic I found interesting was how often do first responders experience trauma or crisis calls, and it had up to 50% of emergency calls to dispatch are related to a mental health crisis. So again, just showing a significant need for assistance in this area.
What are crisis intervention teams? The lack of mental health crisis services across the United States has resulted in law enforcement officers serving as first responders to most crises. A crisis intervention team, CIT, program is an innovative, community-based approach to improve the outcomes of these encounters. You can see here two symbols, the Heartland chapter, the crisis intervention teams of Nebraska, and also the CIT regional map of Nebraska.
CIT programs first came about as a result of an incident that occurred in 1987 in Memphis, Tennessee. Memphis, Tennessee dispatch received a 911 call that there was a man that was with a history of mental illness that was in crisis. He was self-harming and threatening suicide. When officers responded, the man became more upset, took a weapon, and ran towards the officers. They then discharged their firearms, killing the man. As a result of this event, the Memphis Police Department joined with the National Alliance on Mental Illness, or NAMI, mental health providers, and 2 universities to organize, train, and implement a specialized behavioral health unit within their department. In 1988, NAMI, the National Alliance of Mental Illness, provided the first grant that helped fund this Memphis Behavioral Health Unit, which was known as the Crisis Intervention Team. Since that time, CIT programs have been funded, trained, and implemented across the nation and worldwide. In 2008, CIT International was founded to assist communities worldwide with crisis response system reform by developing CIT programs at the state or province level, regional level, and local levels. They utilize research and experience to define and advocate for the best practice standards of CIT programming. As of 2019, there were over 3,000 CIT programs, nation and worldwide. In the Nebraska area, in 2006, the first CIT program was initiated in the state. Douglas County Sheriff's Office and the Omaha Police Department began adopting the CIT philosophy in Nebraska Region 6 area. The rest of the regions in Nebraska have varying degrees of capabilities and are currently working towards training their law enforcement professionals at various stages depending on the region. For example, one of the events that we will be talking about later in this presentation that was held in Grand Island was the first ever training for CIT that was conducted outside of the Omaha metro area. So they're really working hard towards growing CIT programs throughout the state.
This is a list of the current committee members that are represented for Nebraska CIT. You can see the executive committee members are on the top with the white background, and the project committee members are in the green background.
Now we just have here some facts around crisis intervention teams. So first, they are usually community-based programs that help to bring together law enforcement individuals, mental health professionals, and other areas of mental health advocates, and outside partners as well to improve the community responses to mental health crises within that specific area that they're working for. Crisis intervention is not just about how law enforcement responds to a mental health crisis situation. It also looks at how mental health professionals and outside support systems are involved in that crisis response and how well that team works together to de-escalate or resolve that crisis situation. CIT evaluates how different support systems can better help someone that is in a crisis before it actually gets to the point where it's out of control and goes beyond the point of de-escalation being able to happen with that individual.
Okay, our next slide is the crisis intervention team members. They are a team of emergency care individuals such as first responders, social workers, counselors, psychologists, and other mental health professionals who are collected to address a crisis which cannot be resolved through traditional law enforcement approaches to manage the situation and prevent serious consequences. Some of the goals of the crisis intervention teams are they increase officer and consumer safety. They're going to redirect individuals in crisis away from criminal justice system and toward treatment and recovery. And they're going to reduce stigma for individuals in crisis and serve people with mental illness with respect.
So along with the goals that are in place around CIT, we also take a look at how the success of CIT programs is measured and kind of what that's based on. So first, it's really based on that network of relationships. So the law enforcement officers, the mental health advocates, the other support systems that can come in, like family, peer supports, and social workers and things of that nature that can all come together to help resolve a crisis or help de-escalate that crisis. The second way the success is measured is the ongoing commitment to the programs and to making sure when a crisis comes in that the whole crisis team is committed to going out together and working together. 3, understanding of community-wide response. So that that's really just trying to get everyone on the same page and training everyone on how that looks in their specific community. For strengthening of crisis response teams. 5, training programs for dispatchers and law enforcement. So that's the one we actually attended in Grand Island last month, was a training program specifically for law enforcement officers. I'm not 100% sure if there was dispatchers there too. But the law enforcement officers were who went through the whole week long training, and then who we were evaluating in these made up crisis situations, that they had to go in and try and de escalate the situation. And then lastly, is commitment to ongoing improvement and engagement of this program. The training that we went to in GI was actually the first CIT training that was held out here in Western Nebraska. Before, they've always been held in Lincoln or Omaha. So that was cool to be a part of and see area law enforcement officers come together and participate that. So that commitment to just making sure that not only the program is improving and continuing on and continuing to get people or get officers through these trainings, also the engagement and how well they are able to recruit people to the trainings, and how engaging the whole training process is for these law officers.
Some of the benefits in addition that will go along with the crisis intervention teams are they bring community leaders together. They're going to keep people with mental illness out of jail and in treatment where they belong. They reduce arrests of people with mental illness. They give police officers more tools to do their job safely and effectively. They're going to keep law enforcement's focus on crime, and they're also going to produce a cost savings. Some of the barriers that these individuals are going to face are, we talked about it a little earlier, is just the stigma, which becomes a major barrier between first responders and the individuals struggling with the mental illness. And these, first responders don't really understand what the signs of a mental health condition look like. And so as a result of that, they don't always respond appropriately. And many times both parties are viewing the other one as a potential threat. And so then they respond accordingly. Another barrier that was listed is developing and financing. So just how do we go about developing these programs so they're effective and efficient, and also that we are able to finance them? Trying to find the funding that's out there to be able to bring in these teams and better help also can become a barrier. And then there are existing laws out there as well that pose a challenge. As far as how to establish and dispatch certain response approaches is what it said. So, how we go about responding to these, they just have a different, there's laws in place that may also cause some issues with us being able to respond appropriately just based on the protocols that are already in place. Crisis intervention teams on this next slide, we've kind of listed out what the core principles are and what it's based off of. And it's dignity, understanding, kindness, hope, and dedication. And training is based on the concepts of improving communication skills. So helping these first responders go into these situations where they can de-escalate the situation versus escalate it. And intentions typically are, for these law enforcement individuals not to escalate it, but sometimes it's just a lack of knowing how to communicate with them so that they can help, de-escalate what's happening. And also just understanding mental illness. And we'll talk a little bit in some of the other slides coming up here, but there's a stigma attached to people with mental illness. And so as a result of that, these training sessions and helping law enforcement and other first responders just better understand what mental illness is and how we need to care for these individuals will also help, create a that more euphoric situation than where we're at today. And then crisis intervention training, just a little more detail on that. It's a 40-hour training course, and it's taught either by local behavioral health professionals, police trainers, or advocates. Training goals are to understand signs and symptoms of mental health issues and co-occurring disorders, to recognize when signs and symptoms signify a crisis, carefully de-escalate individuals in crisis, and also to use diversion strategies and communication resources to help individuals in crisis receive the care that they need.
All CIT training is standardized across the nation. And to achieve the goals that were previously mentioned, they utilize a building block methodology for the training. There are 3 blocks, the first block being knowledge. And in this block, it aims to provide officers a basic understanding of why and how people may experience crises. They are provided basic knowledge on mental health conditions, the signs and symptoms of these conditions and mental health crises, and mental health services and nonprofit organizations that they can leverage to support the people that they encounter that are in a crisis situation. The second block is experiencing, sensitizing, and building empathy. In this block, officers are exposed to people with mental illness as well as family members. So they can hear directly from those who have life experiences similar to the people they may encounter in a crisis situation. They also are exposed to mental illness through various exercises to help increase their understanding, such as the hearing voices exercise that many of us have actually experienced ourselves in our diagnosis class. The third block is experiential practical application. Now this is where the officers actually get to use their newfound knowledge and understanding within a practical exercise environment. Skills that are taught that they actually exercise include empathetic communication, non-threatening body language, and tactical management of the scene to ensure safety. We'll discuss this more in later slides when we describe our own experiential activities coming up.
So for our experiential piece of the project, Amanda actually got to participate in a ride-along with a Kearney police officer. And so the next couple slides the next slide is her going into more detail about that and what that experience looked like and the different things that she learned from that experience.
So this is Amanda King speaking, and I had the opportunity to ride along with Officer Lacey Lindner on November 7th, and it was an interesting day. So the day started out about 9 in the morning. I met her down there at the police station. We took a tour of the precinct, met quite a bit of the staff, and as she was giving me a tour, she got a call to go out to a disturbance at a local motel here in Kearney. When we got there, the gal had been kicked out of a motel because her kids were running around the lobby and being disruptive. She had 2 young boys. I would say one was probably around 8. The other one was maybe like around 12. And she also had at least 5 small animals in 4 small pet crates. And the dogs were yapping and the cats were meowing pretty loud. Because I wasn't able to get out of the car, she was able to put on a speaker on her collar or a microphone actually, and I had the speaker in the car so I could hear everything that was going on. So the officer attempted to assess the situation and had asked the gal whose name was, her name just left me. Oh, it was right on the tip of my tongue. Sorry about that. The gal was trying to explain, or Officer Lindner was trying to find out what was going on. So what had happened was she got kicked out of the one motel, walked across the street to another motel. This was in the Eunice Motel District. And that motel then called police to get her off not only both properties, but off of all Eunice properties. So as we got there, like I said, this was probably around 9:45 in the morning, and it was pretty cool, chilly, but both boys had shorts on, and they were just sitting outside the door. Erica, her name was Erica. Erica and her two sons, we never did get their names, or at least I didn't. Erica then proceeded to just get angry at Officer Lidner. She had been dropped off from somebody from Sydney, but she wanted to get back to Sydney. She refused help from the Safe Center. She refused help from DHHS was called, but didn't see that it was a crisis state or needed any intervention, from what I could tell at that moment. Now, we were called out there 2 more times during my ride along. Anyway, Erica was not happy with the officer, the female officer, and so a male officer was called in and attempted to defuse the situation, and we then had to leave. So later, as I was asking Officer Lindner, what are her obstacles? Why did she become a police officer? As you can see, there's a quote here, but also, what are her challenges in being a police officer? And she had said, I became a police officer to help people, but a majority of my time is spent diffusing tense crisis situations. Oftentimes, people are less likely to confide in a cop than they are an EMT or doctor due to not liking or not respecting cops or afraid of getting arrested, which puts me in a difficult situation to be of any support. So she had said that happens frequently. When asked for details or information or trying to assess, they won't answer or they shut down. But if a EMT or they get transferred to a hospital, they are just, she said, way more willing to disclose information because law enforcement isn't around. It was really interesting. There's a whole nother side, I would say, to just civilian life when you're in a police car. So it was really insightful. But yeah, I got to see firsthand on some of her challenges in working with civilians in a semi-crisis state.
And then for another activity that is related to our project, Anne and I had the opportunity through our practicum class to attend the basic CIT training that was held in Grand Island this year at the Nebraska Law Enforcement Training Facility. This is actually the first one that has been held out west here, so that was cool to be a part of that experience. So what this an overview of what this entailed was, it was a week-long course. The first 3 days were the officers were in the classroom and learning things about the CIT training and doing exercises. So like I mentioned earlier, 5 of us practicum students went, and we had different roles during the 2 days we were there. So we came in at the end of the week to help with the scenarios that they had made up for these crisis intervention teams. And so some of us served as actual counselors and evaluated the officers. And on the next couple slides, we go into more detail about what our actual roles and responsibilities were as the counselors while we were there. And then what that evaluation sheet looked like that we were using to score the officers that were participating in the scenarios. Anne had the privilege of being an actor in the scenarios with Jeff, as you can see in the picture. And then also there were other law officers there that were evaluating the officers with us, and family peer support specialists were there evaluating as well. So like I mentioned, they went into these setup scenarios and had to de-escalate the crisis as well as they could, and they got a 10-minute time frame to try and either de-escalate it or get them other resources or get them to agree to go to another resource for mental health help. So, like mentioned earlier, the people that were kind of really involved with this CIT training that we attended in Grand Island were the mental health people, and then there was other people who were the actors, so they were actually acting out the scenarios, and then the law enforcement and the peer specialists that were helping evaluate the officers with the counselors. Our As the counselors, our specific roles and responsibilities. So we were split up into different teams. Anne actually got to be an actor in the scenarios, so she wasn't an evaluator, but I was able to be an evaluator both days. So we were split up into different teams. Each team consisted of a counselor, a family support specialist, and then a law enforcement officer. All three roles served as evaluators and making sure the officers in the training were taking the proper steps to de escalate the situation that was being played out. After their time was up to try and de escalate that scenario, we then went into like a debriefing with the officers that participated in the scenario and with the other evaluators and gave them feedback on what they did well and maybe something that they could improve on or work on for that situation. All the officers participating in the trainings were sent into 3 different scenarios over the course of 2 days. And it was really interesting as an evaluator to see, everyone's perspective of how they were evaluating these officers. So I was obviously evaluating from a counselor point of view, and then the law enforcement officer that I was with, he was looking for different things to evaluate them on. And then the family support specialist, I think is what she was called, she was kind of along the same lines of looking for the same things as I was. But still, there was like a few different things that she was able to pick up on that I wasn't able to pick up on.
As Jessica stated, the other role that we as counselors or mental health professionals provided during the CIT training was we were actors. So actors, we really required an expertise or knowledge of the mental illness that was being portrayed within the scenarios. So they prefer to have the mental health professionals or peer support specialists to be the ones that are the actors because they have the experience with understanding some of the mental health issues that we were portraying within the scenarios. And so we had different roles as actors. Either we were the person in crisis or we were a family or significant other. And within those roles, then we were told to cue off of the officers and their actions on whether we escalated or de-escalated the situation. And then we were also provided some other goals during the scenarios. For example, we were told to distract attention away from the person in crisis. So Jeff and myself, we were actors together, and he was a person portraying a schizophrenic, and I was his wife. And so I was told to try to distract the officers from him who was in crisis, so they actually understood how to be able to control a situation where they had multiple people involved because they would likely be confronted with those areas and those issues. So our level of expertise of understanding it was a schizophrenic, and the other one was a person with depressed state who was self-harming. So understanding how a person would in crisis would be acting, the characteristics they would be portraying, the reactions they would have to an officer who's trying to get them help, that really helped us portray a realistic environment for the officers to train in.
And then this section of our presentation just kind of goes over what that evaluation sheet looked like and what kind of the categories of it were, of what we exactly were evaluating the officers on. Unfortunately, I don't have a picture of the sheet, so I just have these categories listed here. So the first one that we checked off was the officer stated their name and their partner's name, or their partner stated their own name. And we also were supposed to watch and make sure they were asking for the citizen's name, whether it was one person or it had multiple people in the scenario. They were supposed to be making sure they were getting the names of all the people involved. The second category was making sure they were asking about any current medication use or substance use. So this one was actually like 3 subcategories. So there was a box we had to check off for: did the officers ask if they had taken any medication that day? Did the officers ask if they had taken any or drank any alcohol that day? And then did the officers ask if they had taken or used any sort of drugs that day? And then the third category was that they established officer safety in each scenario. This one was interesting to watch because it's not really in my realm. But the law enforcement officer that was in our groups with us that's really what he was watching for. He knew what they were supposed to be doing, and so seeing that was cool. The fourth one asked about mental health supports. So if they had like any outside resources to help them with their crisis situation or their mental health situation, and then also if they had a therapist or if they were thinking about going to a therapist to help with their situation as well. Fifth, if we had to make sure they were asking about any past mental health history that they may have had that led up to this point. 6, they needed to ask about any suicidal thoughts or plans. 7, also any, under that category was also any like self-harm things. 7, provided the citizen in crisis or their support person with outside resources for help. If it got to a point where they were able to de-escalate the situation, then they were supposed to offer outside resources that they could use if they fell back into this again. And then lastly, which is something that I was really looking for, was showed empathy and concern to/for the citizen. That was a big one that they really wanted us to watch for, was to make sure that they were actually trying to show the citizen empathy and not just saying like they got docked points if they said like, I understand what you're going through, or I've been through something like this before too. We were supposed to dock them points, so really making sure they were hitting on empathy and concern for the citizen and gaining that trust with them and building that rapport with them.
So what does this mean for us as counselors? Being involved in our local CIT efforts can provide us with many opportunities within the multicultural, social justice, and advocacy arenas, and ultimately it can help us professionally. Whether we are helping establish our local CIT program or joining an existing program. Supporting and working with our local CIT programs will allow us to serve our clients and communities by helping train law enforcement officers. In doing this, we can help lessen the trauma associated with crisis situations that people may experience, advocate for underserved populations. We can expose law enforcement officers to multicultural aspects that they may not be aware of, and we can work towards equality of all populations. And finally, we can lessen oppression and decrease the law enforcement burden that they encounter when they are dealing with these crisis situations. Being involved in CIT efforts can also build our understanding of what our clients may go through if they've ever been in a crisis situation where law enforcement officers have responded. It can give us an appreciation for what they went through during that event. It can also help build our understanding of the very things that I just said we could help train our law enforcement officers on. They're seeing things from a different perspective daily on the ground within our community, so we can learn from them as well, which can help us better serve clients when they come to see us. Another huge part of CIT program is building and strengthening mental health professional resource service networks. So really building that community of professionals that we can leverage either for our own clients or that we can support with our own areas of expertise. Ultimately, the more people that we have involved, the greater we're going to be able to serve our communities and do better for them. CIT participation can also allow us a venue to provide more community outreach and services. We may get more client referrals as being a part of this network. We can offer and curtail group counseling that we provide to the community. And we can also participate or maybe even develop educational programs on mental health issues that may help our community members and our clients. Another area where our participation in the CIT program may be beneficial is that we will be helping increase community exposure to mental health issues and services. And we can help lessen the stigma surrounding mental health, not only within the community. And finally, one of the most important things that we could possibly help with is working to increase resources, financial resources, policy resources that can help not only us as counselors being able to serve our clients, but as well as increase the other services that are provided to our community members. Ultimately, this project has allowed us to have a greater understanding of what law enforcement officers have to go through, but as well as our client base of what they may be experiencing if they are ever in a crisis situation. And we have learned that we can have an active part in making a difference in our community by helping with these CIT programs if they are available in our area. We appreciate your time and consideration in watching this presentation. If you have any questions, please feel free to reach out to any of us, and we will do our best to answer them in a timely manner. In the next slide, you will see all the resources that we used to compile this presentation. Thank you.